The aim for this study was to develop a standardized outlook focusing on early identification, intervention, and rehabilitation for silver trauma to reduce morbidity and mortality. Silver trauma refers to traumatic injuries in patients aged 65 and above. As per the NHS, falls are a leading cause of emergency hospital admissions for the elderly and impact their long-term outcomes. We conducted a retrospective analysis of patients aged 65 and above presenting to the hospital with a fall. Data was collected as 2 cycles over a period of 2 years. Primary outcomes being incidence and patterns of injuries missed at the initial assessment. Between the 2 cycles, a silver trauma guideline was introduced as a screening tool for injuries, which goes as shake, rattle, rock and roll, and followed by a 24-hourly stretch and roll guideline. In the first cycle, 56% patients were identified to have an injury at the first clinical assessment, compared to the 36% in the second cycle. Looking at a few other variables, what we can see is that in the first cycle, the rate of missed injuries was 6%, which was reduced to 4% in the second cycle. 47% of those with missed injuries in the first cycle had cognitive impairment versus 62% in the second cycle. 3 of the 19 patients with missed injury in the first cycle had a change in their clinical journeys, compared to 6 out of the 15 patients in the second cycle. There was no correlation between missed injuries and the time of the day of presentation, and no injuries missed at ED was picked up at AMU clerking. All of them were picked up at ward reviews into the admission. The study highlights the diagnostic challenges and impact of missed injuries in older patients presenting with falls, also accounting for cognitive impairment at the same time to avoid diagnostic oversight. Notably so, however, nearly half of the patients with missed injuries in both the cycles had no cognitive impairment, indicating that preserved cognition does not immediately protect one from having a missed injury. Our findings show the need for targeted guidelines on reducing missed injuries and improving clinical pathways. Following the introduction of the guidelines, there was minimal documented use of it during the period of data collection, and the rate of missed injuries remained comparable in both the cycles. Hence, going forward, our focus is on staff education, simulation training, and prospective evaluation of the guideline effectiveness to ensure full uptake and embedding of the SRRR tool into routine practice. Thank you.